Good evening, everyone. Welcome to another Society of Pediatric Echo Speed webinar. I'm Neha Soni Patel, co-chair of the Education Subcommittee, along with Jen Kovu. And tonight's webinar is Imaging Interstage Tips and Tricks. Thank you all so much for joining us. We are so excited to present this, and especially because there's so much that we can learn from just a little bit of time each in this evening, the 30 minutes. Just like our peds echoes, we got to be straight and to the point because that kid will lose their mind otherwise, right? So as you know, these speed webinars are only these 30 minutes, and our goal is to share knowledge and foster learning and collaborations among the sonographers, fellows, and physicians. As you've noticed, these are free webinars, and if you are a member, there is a half a CME associated with this. So take advantage of the 50% off we have currently for all memberships. The deadline has been extended, so I encourage all of you to become members. This platform is informal and brings together bright and inquiring minds to share their knowledge. So please type in your questions into our chat box, and we'll be sure to try to get to them at the end. We'd like to thank our institutional sponsors, Lurie Children's, Cincinnati Children's, Lucille Packard Children's at Stanford, Nemours Health, and Seattle Children's. If your institution is interested in being a sponsor, please email us. The fourth Tuesday of every month is dedicated to speed, so join us next month at 8 p.m. also. A few housekeeping rules for tonight's webinar. Please stay on mute as we'll try to start each speaker with their talks, and then we'll proceed with the Q&A session. Type in your questions into the chat box or raise your hand at the end, and so we can get your question in hand. I'm now going to hand this over to my co-moderator. So I'll be moderating along with Dr. Nitin Madan. He is an imaging cardiologist from Children's Mercy. Nitin, take it away.
Thank you, Neha. Welcome, everyone. I would like to introduce our first two speakers who will be tag teaming today. So we have Samantha Holmes, who is a third-year pediatric cardiology fellow at Children's Colorado. And she plans to stay on at Children's Colorado for her fourth-year training and specializing further in fetal echocardiography. And I also have the distinct pleasure of welcoming my colleague and mentor, Dr. Shirali. And Dr. Shirali is an echocardiographer at Children's Mercy, Kansas City, and he has dedicated his career on using echocardiography to optimize medical and surgical decision-making. So take it away, folks. Thank you.
All right, so overall, thank you guys for the kind introduction and giving us the opportunity to be able to present on echocardiographic evaluation post the Norwood procedure. As mentioned, we'll be doing this together. So looking at starting off with discussing the goals of a Norwood operation. Ultimately, the goal is to provide free mixing of systemic and pulmonary blood flow while also allowing for unobstructed systemic blood flow and controlled pulmonary blood flow to advance to a successful fontan. Looking at the components of the Norwood here, so we have an atrial septectomy that's performed to achieve the free mixing of the two inflows. And then to allow for adequate systemic blood flow, we create a giant neo-aortic arch. It's created by utilizing the pulmonary valve, pulmonary artery, native aortic arch, and native aortic valve. And connecting the native aortic valve and coronary arteries here allows for coronary blood flow. And this is what's called a DKS, or pre-coronary anastomosis. So finally, you can see that we also have to include a shunt. That's either a BTT shunt that's usually seen here, or on this picture, we have a Sono shunt. So the Norwood entails multiple components, every one of which can become a postoperative issue. The red bullet points listed here are aspects that are amenable to diagnosis by echo, and intervention may well be needed on. These include the atrial septum, the shunt, pulmonary arteries, the DKS, the aortic arch, RV function, and tricuspid valve regurgitation. In this presentation, we're going to focus on images of both normal and abnormal appearances of target structures post-Norwood. Due to time constraints, we won't be addressing RV function and tricuspid regurgitation in this presentation.
So every Norwood is different. And one of the things I like to do when I read an echo on a patient who's had a Norwood is to review their op report and their prior echo report or reports before I start performing and reviewing the echo. The next thing is that unless otherwise requested. For example, a patient who is an extremis. I like to assess all components. So I think it's important to go in with a plan. And I really, I'm a big believer in post-Norwood imaging echo protocols. I like to make sure that I take care with carrying forward prior echo reports, just because things can change. And in fact, that's the reason why the serial echoes are being ordered. And so we just want to make sure that that we do our due diligence with that. The last thing that I think is perhaps not emphasized a whole lot, but again, I think is very important is the concept of standardized reporting. From, in some ways, I think reading an echo is an art. And so people might like to freeform with that art. But from the point of view of the clinician who's looking at the echo report, I think it may be more advantageous to look at it as in a standardized kind of way. So the way that I think about the Norwood in my report is I start out by assessing all of the by basically addressing every component of the Norwood that was evaluated on that echo and any changes in any of those. Then I talk about ventricular and valvular function, and I finally end with effusions.
So looking at some echo pictures, so starting by evaluating the atrial septal defect. So this is really important to make sure that there is free mixing of the systemic and pulmonary venous inflows as described. And in this subcostal sweep here, we can see that there's large non-restrictive atrial septal communication. And you compare it to this image here on the left, we can see that this patient has a pretty restrictive atrial septal communication. There's turbulent left to right flow, and there's blunted phasicity of the flow. And the gradient that we're seeing through here is almost 7 millimeters of mercury.
So from by way of practical pointers for the atrial septum after a Norwood, I like orthogonal sweeps used using both 2D and color flow. I like to use low scale so that we can actually see the flow clearly, and I like to measure the diameters of the one or more defects in these orthogonal views. The things that I think are of potentially interventional, that have some relevance from an intervention standpoint, have to do with the length and the thickness of the remaining atrial septum and the size of the left atrium. Because if the interventionists are going to be thinking about going in there and ballooning it or doing something about the septum, then the thicker the septum, the smaller the left atrium, the less likely it is that they're going to be able to achieve a whole lot with the transcatheter approach. The Sano shunt is the next thing that we're going to be talking about. So one of the things to keep in mind with it is this is a three-dimensional structure. I think it's very difficult to try to get the magic picture that shows the entire shunt. So I like to use the segmental approach to evaluate the shunt for obstruction. So I start out by looking within the right ventricle for what I call pre-Sano stenosis, which is in the form of muscle bundles within the right ventricle. So if the Sano went in right adjacent to the anterior papillary muscles, the tricuspid valve, for example, that could lead to stenosis. The Sano itself will be patent, but there won't be enough flow coming into it. And the next thing is that there can be kinks or acute angulation in the proximal portion. The third thing is there can be thrombovegetations within the shunt. And then the last thing is anastomosis of the shunt to the pulmonary arteries. One of the big caveats that I like to think about has to do with gradients through the BTT shunt as well as the Sano shunt. One of the things that I see with sometimes with echo interpretations is a degree of concern with high gradient across the shunt. Keep in mind that especially when you're using color flow, when you're using continuous wave Doppler and given normal blood pressure, which is high, and low PA pressure, which is normal, a high gradient across the shunt is to be expected, not something to be worried about. And as babies grow a few weeks and months older, their blood pressure tends to go up. So the gradient across the shunt is going to go up even further. It doesn't mean that the patient is outgrowing the shunt. It just means that there's a high gradient across the shunt. That's it. So I think there are important caveats regarding how to use these clinically. So, thinking about treating the patient and not the gradient.
So looking at the sinus shunt on echo here, so starting on this left image as described, you kind of have to go through this segmental approach. So here we can see the shunt as it connects into the right ventricle. There's good flow through the sinus shunt from this proximal portion. And then from more of a suprasternal view, you can see good flow through the shunt as much as you can. As mentioned, it's a three-dimensional structure. And so really getting a good sweep through the shunt can be rather difficult. And following the blood flow. So we follow the blood flow through the shunt, and now we're getting to the distal end of the shunt into the anastomoses to the branch pulmonary arteries. So here we can see the sinus shunt as it inserts into the branch pulmonary arteries. There's good flow through the shunt. There's good flow on this image, the left pulmonary artery. And on this right image, we can see our neo-aortic valve, and we can see good flow from the shunt to the right pulmonary artery. Now, looking at the pulmonary arteries themselves, sometimes it's difficult to get both pulmonary arteries in view. And looking at this suprasternal view, so this is a good sweep here where we can see flow into both the left and right pulmonary arteries. And here there's adequate flow through both of those as well. The importance of looking at the branch pulmonary arteries because you can get pretty severe stenosis over time. So this is an example, and you can see in 2D that this is a very small pulmonary artery. And trying to get color flow through that is very narrowed and the velocity looks pretty high. So we talked a little bit about the sinus shunt. So thinking about a BTT shunt, the shunt that comes from the subclavian, usually to the right pulmonary artery. And so here we can see that this portion, the distal portion of the BTT shunt, as it enters into the RPA, there's good shunt flow through here. There's good shunt flow into the pulmonary artery. In comparison here, you can see that there's pretty significant narrowing of the BTT shunt distally, and it's just proximal to the pulmonary artery. Something that's interesting that you can also have with a BTT shunt is you can actually get narrowing of the subclavian artery proximal to the BTT shunt. And so here on the left, you can see an echo image where we have the BTT, the subclavian artery as it enters into the BTT shunt, and it looks pretty narrowed. And on the right, we have a really beautiful angiogram where you can see contrast flow through the right subclavian here, BTT shunt, and there's some pretty significant proximal narrowing that may require intervention.
So from a practical standpoint, as far as the pulmonary arteries go, again, I like to use sweeps. I also like to use X-plane imaging. So, but for those who are not familiar with the use of this, you use a 3D transducer for this. So in a baby of this size, we do use the X72 transducer. And when you activate X-plane, you end up getting an orthogonal view. So if you're at 0 degrees, you'll just get a 90-degree view. And so it's a really good way to look for shunt stenosis at one end or the other. And you'll end up seeing aspects of the shunt that are not conventional with typical 2D imaging. So I think it's important to get familiar with the use of X-plane to be able to look for localized shunt stenosis. It's uncommon for the entire shunt to become stenotic. So usually we're looking for localized things. And I think when you're looking for localized things, you just have to know that the stenotic area or the fold may be in one plane and not in another. So looking at it at both at the aortic end and the pulmonary end, as well as the mid portion, is important. And as we saw with the previous demonstration, looking at flow proximal to the shunt is important as well.
So looking at the DKS, or the precoronary anastomoses, here on the left, you see a pretty open DKS with good flow. In comparison, here on the right, you can see there's pretty significant narrowing of this DKS. This patient ultimately did require revision of the DKS prior to their next stage palliation.
From a practical standpoint, with the evaluation of the DKS or the precoronary anastomosis, the first thing is that if the native ascending aorta is less than 2 millimeters in diameter, it's not realistic to expect an anastomosis that is going to be much larger than 2 millimeters in diameter. That just doesn't, they can try to bevel it or whatever, but at some point, that's just what you're going to have. The second thing is that I think that off-axis views and sweeps of the area of the neo-aorta, looking for the DKS can be helpful if you can't see it in standard on-axis views. And the reason for this is because the surgeons make the anastomosis wherever the aorta, wherever the two of them align well, the native and the neo-aorta. They're not exactly looking for the most eco-friendly orientation of those two great arteries. So just look all over the place, I guess. And then the last point is that echo can be deceptive for assessing coronary arterial flow, and especially the adequacy of coronary arterial flow post-Norwood. I think other modalities are required to figure that out.
So looking past the DKS into the neo-aortic arch, it's important to really evaluate this because we know there's significant aortic arch reconstruction that occurs in patients that have a Norwood procedure. So on the left, you have really good adequate aortic flow. In comparison, on the right here, you can see that there is a narrowing of the isthmus just distal to the DKS with pretty severe coarctation that will likely need repair.
So one of the things that we encounter just about all the time in patients who've had a Norwood is the size discrepancy that normally occurs between the reconstructed or the neo-aorta and the native aortic diameters. That in and of itself is just inherent to the Norwood, and it is not a cause for concern. The second thing to keep in mind is that gradients can be affected by RV systolic function. So if your function isn't that great, then you might have a hard time capturing a great gradient through there. And the second thing is, remember that especially in patients who've had a BTT shunt, there is pop-off into that shunt. And that makes it very hard to depend on gradients through the arch. So I like to measure the arch, the narrowest part of the arch, the diameter of it, and follow serial measurements of that in addition to gradients. The next thing to keep in mind is that when you drop a Doppler through the post-Norwood coarctation, diastolic runoff is quite rare. And that's because, again, of pop-off into the shunt. And then the last thing is that this is one lesion, recoarctation post-Norwood, is something that typically develops and worsens over several weeks. Just as coarctation tends to make babies ill first, over the first 2 weeks to 2 months, the same sort of deal is the scarring and scarring down of and contraction of residual ductal tissue. So serial study is really important here. And again, the concept of being careful with the carry forwards on the echo reports.
So this patient is actually really interesting and had a pretty unusual postoperative issue. So looking here, we see our neo-aortic valve, and there's actually stenosis, and you can see the increased velocity through the proximal portion of the arch reconstruction, just distal to this neo-aortic valve in the DKS. Unlike the other coarctation that we saw that was more distal, which is where it's usually seen. So this patient ultimately had a 45 millimeter gradient through this area, which did require surgical intervention. So really, in summary, comprehensive echo evaluation requires a systematic approach to study performance and reporting. Echo can help diagnose the vast majority of post-Norwood structural complications. We hope we've provided a basis for what we call actionable intelligence. This refers to clinical, meaningful echo reporting in this fragile patient population. Thank you, and thank you, Dr. Shirelli, for all of your help with this presentation.
Thanks, Sam. You did great.
Thank you.
Thank you to the both of you. That was a really great presentation. I have to say I was a bit jealous about how beautiful those Sano pictures were. But right away, we're going to go into our next speaker. Dr. Karen Texter is a pediatric cardiologist with the Heart Center and Nationwide Children's Hospital in Columbus, Ohio. All great pediatric minds lead to Ohio, so all roads lead here. She specializes in the non-invasive imaging. She's the director of their single ventricle team and fetal cardiology program. All right, it's your turn, Dr. Texter.
Okay, well, thank you so much. Nice to get to see everybody. I'm hopeful that you can see my screen. Yes, okay, thumbs up.
Yep.
Wonderful. Again, thank you so much to the moderators for having me with you today. We're going to touch base on the assessment of the Interstage HLHS patient after hybrid. hybrid stage 1. Let's see. My slides aren't advancing. Hold on. Okay, here we go. So for our short time together, I'd like to touch base on some of the pertinent anatomy for pre-op imaging, because that is so very important. We'll talk about the normal interstage findings for the hybrid patient after hybrid stage 1, and then we'll touch base on some of the common red flags that suggest that your patient may need an interstage intervention, or at least you should consider looking at evaluation with a cath. So again, touching base on the Norwood operation on the left, the differences with the hybrid, then we have the PDA stent as opposed to the arch reconstruction. That's so important because then our systemic blood flow being through the PDA stent, going down to the descending aorta, and then that retrograde arch area that is the Achilles heel of the hybrid palliation. And then we have the bilateral PA bands, as well as the atrial septal defect being addressed with the balloon, most commonly a balloon atrial septostomy. So that atrial septum's opened all interventionally. So real quick, I'm going to fly through this part so we get to more of the meat. Before your hybrid stage 1, of course, you want to look at your anatomic imaging, understand your anatomic variant for HLHS, ventricular function and risk. Important to get a sense of what that ascending aorta is. And here we are in the peristernal long axis looking at our ascending aorta, hypoplastic, but not as small as some, as you may see, with a hypoplastic native aortic root. Since that PDA is going to be stented, we always want to get really good 2D pictures. Here we are in the suprasternal notch view looking down at our PDA. Sometimes our interventionalist will ask us to actually measure the diameters, make sure that's unrestrictive. The atrial septum, just as our first speaker team mentioned, to look at the atrial septum. If you're going to address that interventionally, you need to get a sense of the thickness. I like to look at the mobility. Is it thin and floppy? The location and number of your defects, so that the interventionalists know where you're going to go. Sometimes your atrial septum anatomy is quite complex, and that will significantly affect how we approach the hybrid procedure, if they need biplane or not. And sometimes we'll even separate out the BAS from the initial bands and stent. And then that Achilles heel, looking at your arch imaging. So prior to the hybrid, you really want to get a sense of what is that retrograde arch flow going to look like. That's your backwards flow coming from the PDA stent. So here we are in the suprasternal notch view, tipped out of your PDA. So commonly for HLHS kiddos, as we know, their transverse arches are small, their ascending aortas are small, and so frequently that arch doesn't sit quite as high on top of the ductus as it does in the normal heart, and it'll be more to the side. So this picture is taken from the suprasternal notch view, but tilted towards the side, kind of looking at the orifice of that retrograde arch. So you want to get a sense of the width of that area. There we go. Is that area nice and broad, or is it real narrow, called a congenital retroaortic arch stenosis? That's really, really rare. I like to then confirm that with the color flow, the width of my color jet, and then we'll Doppler in that area as well. And anything less than 2 meters per second really is all consistent with that's going to be okay. Now, certain anatomic variants can be concerning. And here we see a patient who has that really small diminutive ascending aorta. And in that setting, you do have to be worried that your junction with the isthmus and your ductus might be quite tight. So here we see where the width of that retrograde arch area is not narrowed, but your angle that it makes with the ductus to the descending aorta is quite acute. I'm looking at this angle right in here, and it's quite narrow, really less than 45 degrees. This is not an absolute contraindication to a hybrid stage 1. When that ductal stent goes up, you're still going to have flow through that area, but it's definitely a precursor or a predictor for retrograde arch stenosis, and you can see that develop as early as 2 weeks of age, actually. So our team would take angle this narrow as a relative contraindication and either look at a hybrid to delayed Norwood, or potentially even just primary Norwood. So now as we look at post-op, so we'll image patients on post-op day 1 to get a sense of their right ventricular function, tricuspid regurgitation, are there any red flags? And you want to get a good sense of your baseline palliation. So here's the PDA stent from the suprasternal notch view. Here you see the proximal area quite nicely. And then we're looking at it by color as the flow goes down to the descending aorta. I want to point out to you, go get a pointer, our descending aorta is down in this plane though. So as that ductal stent comes down and you use your Doppler signal from the suprasternal notch view, it's extremely difficult to get all the way down here. Let's see, there we go. and the true angle of the descending aorta as well to get fully through your stent. So we try to align the best we can, but just know that there's always a part that you're probably not catching. So keep that in the back of your minds. And on post-op day 1, we typically see peak velocities about 1.8 up to 2 meters per second or so, 2.2 at the most, but usually not more than that. Your retrograde arch, here we have the 2D images from the suprasternal notch view on the left, and then the color on the right. Again, nice broad jet with color. And the Doppler on the top, your spectral Doppler velocity, peak velocity, again, 1.6, 1.8 for post-op day 1 is perfectly fine. As we look at those bilateral pulmonary artery bands, you'll see the narrowing and the flow acceleration, narrowing and aliasing of flow at the site of those bands. And then you Doppler with continuous wave Doppler, you'll Doppler the right pulmonary artery here, and then the left pulmonary artery here, and your peak velocity on there and systole is going to be on post-op day 1 in the newborn is going to be right usually about 2.2 to 2.5, somewhere in the mid-2 range usually, and that will increase them with time with as the pulmonary vascular resistance drops. So now getting into that interstage, you're going to see almost all of your Doppler velocities increase throughout the interstage. And this would be an example of a pretty normal PA band for any baby above about a month or so of age. We typically see the peak velocity is going to increase in systole up to about 4, 3.8 to 4.3 is pretty common on the peak systolic velocity. The end diastolic velocity I want to draw your attention to as well, though important to look at the end diastolic velocity too, because that is still representing your distal PA pressure, and problems in your distal PA pressure are probably going to rear their heads in the end diastolic velocity, probably even before your peak systolic velocity starts to go down. But we'll see the PA bands increase over the course of the interstage, as well as your PDA and retrograde arch all increase in the interstage. So here's a 3-month-old. As you're assessing what that those Dopplers are doing as they increase with time in a normal expected pattern, you have to look at, well, how old is my baby and what should I expect? So here's a pretty normal looking PDA stent, normal expected baby movement too, makes our job so hard. But here in the suprasternal notch view, we get a sense of that PDA stent coming down. Here you see your descending aorta down here, and you can see how that PDA stent doesn't align in a straight line with your descending aorta, and that does make your Doppler assessment useful but limited from the suprasternal notch view. So again, I want you to keep that in mind. And here on this patient, normal, healthy 3-month-old who's as an outpatient in the interstage, we see up to about 3 meters per second, 3.2 meters per second pretty commonly. And with preserved right ventricular function, that's usually not, if we were to cap that patient, the gradient would be less than 10, and that does not usually require an interstage intervention. As you look at that PDA stent, I've already mentioned a number of times that that distal area is very difficult to interrogate. And so important to always look at your abdominal aorta for that flow pattern. And here we see the abdominal aorta with brisk pulsatility and a nice holodiastolic flow reversal. That is where that continuous flow within the PA bands is coming from. It's coming from your descending aorta. So you want to confirm that there's no obstruction by seeing nice retrograde flow there. That's a really helpful tool to use. The absence of that retrograde flow is a red flag. And here's an example of a nice large ASD after atrial septostomy. Again, this can narrow up with time, but this is a nice unrestricted ASD. I like to measure the defect by 2D and follow that serially over time. You look at the width of your color jet, any aliasing, and then a mean gradient here is nice and low, less than 1 millimeter mercury mean gradient. So now we're going to get into some issues, and I hope we have time to touch on it. Each of these can be quite significant. So again, it depends on your baby's age in terms of how you look at the post-hybrid echo and what can be concerning and what else is going on with the patient. So this was post-op day 2 for a baby who was really not thriving. Most of the time our hybrid patients are extubated either in the OR or by post-op day 1, but this is a kiddo who was backsliding actually and requiring more positive pressure and had a pleural effusion. On echo, his RV function had been decreasing and there was worse TR. And here we can see on the color jet that this jet is just not as broad. See, as we go distal to the PDA stent, it's broader, but proximally looks a little bit narrowed. And there's a big jet of red flow here coming back at us. Our LPA Doppler, again, for a newborn, still not as high as we expect for an older patient, but very abnormal. Look at that diastolic pattern. Is very abnormal, almost return of flow to in diastole. That's very abnormal. And then our PDA Doppler also was a bit higher than expected for this age. And this patient did have a significant PDA stent obstruction in the proximal area. And so luckily with it being identified early, this was treated with a proximal stent. It just was part of the ductus that did not get covered with the original stent. And this baby continued to do well in the interstage. So very important to find these issues very, very early to restore a nice normal interstage course. So here now is a baby who is 5 weeks old. And again, on echo, we had seen his right ventricle function start to decrease and worsening of tricuspid regurgitation. This was an inpatient who remained inpatient for additional issues with feeding. And our inpatient protocol actually has us follow the echo weekly while they're inpatient because these interstage issues can evolve sometimes somewhat quickly and sometimes even right under our noses, actually. And this was a baby who was on room air, normal vital signs, didn't have any other red flags, just some subtle changes on the echo. And here is his PDA stent. Again, here we see the 2D picture on the left and the color here on the right with some aliasing and a peak velocity higher than I expect for a 5-week-old. Again, out of what's expected for normal for his age, but still not predicting a terribly high gradient for the PDA stent. But remember, I said there's other things that you want to look at, and that abdominal aorta pattern was distinctly abnormal. Here we see that he had almost like a fling pattern in the abdominal aorta and complete loss of that diastolic flow reversal. When you interrogate the tricuspid regurgitation, the peak TR jet estimated RV pressure of approximately 109 plus right atrial pressure compared to his recorded systolic blood pressure of 80/45, so suggested significantly suprasystemic right ventricular pressure. And he unfortunately had a severe residual coarctation. And just like our Dr. Holmes and Chirali mentioned, these can develop usually onset steadily over a couple weeks. And so at 5 weeks of age, we uncovered this. We had just missed the signs actually because it's so difficult to get the Doppler aligned there until we really had a significant obstruction. We didn't see those signs. Again, because it was caught and able to be treated, this baby was able to progress with a pretty normal interstage period and was still a stage 2 candidate. So now looking at our bands, once those bands reach a nice high peak, they really shouldn't go down. They may continue to go up with age, and as the baby grows and grows into those bands, they get a little bit tighter. But this was a 2-month-old baby who had reached a nice high peak, more than 3.5 meters per second on his systolic velocities. But then the peak started going down, and we were definitely losing that end diastolic velocity on his band Doppler pattern. So that's very abnormal, and we know something's wrong. And so when you see that lower end diastolic and decrease in the peak systolic velocity, that's your estimation of your PA pressure. And that can be related to a looser band. And now in our hybrid experience, we haven't had that happen more than one or so, and not in the most recent era. But that can happen. But most commonly, we do see this related to elevated distal PA pressure, usually from true pulmonary hypertension or pulmonary vascular resistance issues. But most commonly, it's actually related to elevated LA pressure, most commonly from restrictive ASD. And that is what this kiddo had. He had a really tough atrial septum. He has mitral stenosis aortic atresia variant with dextrocardia. So everything was just inverted, and it was difficult to get a good result from our balloon atrial septostomy. Here in the 2D picture, you can see that the ASD looks pretty small, confirmed with color, small jet, and aliasing. And then our mean gradient there was a continuous restrictive jet with a mean gradient of 9, and this did need to be treated. And again, he was able to then be restored on a nice pathway and was a Comp2 candidate with normal PA pressure and restored normal LA pressure. So now getting into the retrograde aortic arch, this is a 3-month-old. And here on the top picture, I can see a nice brisk jet. The color jet here looks broad in the transverse arch, but remember the retrograde arch is truly all the way at the insertion at the ductus. And so that's extremely difficult to image because the imaging is obscured by the ductus. And so we do use our Doppler as assessing that to really get a good sense of that. And here we see a peak velocity at 3 months old of about 3 meters per second. That by itself isn't as concerning. Commonly during the interstage, you'll see that go up to 3 or 3.2 meters per second or so. Above 3.3 and definitely more than 3.5, even with normal right ventricular function, that's where you definitely want to start looking for retrograde arch stenosis that needs to be treated because that's a risk factor for poor RV function interstage death. But what's abnormal here really is look at that pattern. You should never have that diastolic runoff pattern in that retrograde arch. This was very concerning. And so she went to the cath lab and had a significant retrograde arch stenosis there. Here, the retrograde arch had narrowed to about 1.2 millimeters, and that was able to be successfully treated with a stent, and she continued in the interstage period. So I hope that I've tried to show you a few examples of the normal interstage after hybrid, and that the echocardiogram findings, mostly the Doppler findings evolve over that interstage period. Really, you should have preserved right ventricular function and tricuspid regurgitation. We don't usually see those progress, and if they do, then we want to be concerned if there is a problem with the palliation. And early recognition of these interstage issues is so essential because they can be intervened upon to restore the baby back to a nice normal pathway. As we all know, taking care of HLHS patients, you got to keep them on the straight and narrow. As soon as they start to deviate, it's hard to get them back in terms of continuing on their standard risk pathway, hopefully. Our team typically uses a PDA or retrograde arch velocity of more than 3.5 meters per second if everything else is going okay, where we have a threshold for looking at a catheterization, unless there's other concerns on your adjunct findings for right ventricular function, TR, your band Dopplers, and that abdominal aorta, because looking at those adjunct findings are so imperative during the interstage and are frequently more illustrative than your Doppler alone. So like I say, I use the Doppler alone only when everything else looks just perfect. But frequently I will cath a patient who has a PDA Doppler of 3.5 meters per second and find the gradient might be 7 or 8, and that doesn't even require an interstage intervention. So the adjunct findings are even more important. Thank you very much.
Thank you so much. This was an amazing overview for Norwoods and our hybrid procedures. So there's one question in the chat. I think Samantha and Dr. Shirali briefly touched on that. So I'll read the question. Question for the audience and senior imagers. I've had a hard time really knowing how to report a gradient across a Sano or a modified BTT shunt, especially ones that are rather tortuous. My understanding of the modified Bernoulli presumes the downstream velocity to be 0, but in these tortuous structures, we can't assume that. However, practically, clinically, I do feel that a reported gradient can have benefit to the bedside clinician. How do you mitigate that?
I think I report the gradient, but I don't typically use just the gradient or an increasing gradient. I think we've heard this from both talks. I mean, the neonatal physiology tends to change over the first few weeks and months after the Norwood or a hybrid, and those gradients changing may just be a reflection of decreasing PVR, or on the other hand, decreasing function. So I report them, but if the question is whether how would I evaluate those gradients as an indicator of shunt stenosis, I would need to see the shunt stenosis by 2D and color flow to be able to make that call, I think. I've certainly seen my share of troubles when a patient was clinically stable but who had a high gradient got their shunt ballooned and then flooded their lungs after that. So
yeah, I completely agree. I think Jen also had her thoughts on this. I think that gradients, are probably helpful just as a serial basis on the patient. And if there is a remarkable change, then sort of looking at the 2D and the color. Also, yeah, like you said, I think modified Bernoulli equation doesn't hold really well in this. So it should be probably further down in the report rather than the first thing, like mentioning whether you see that the shunt is well patent by 2D and color Doppler, and then you can just say the gradient is this much, and I usually leave it at that.
All right. It looks like we have one other question. For early post-surgical coarctations, how many weeks post-op are your programs comfortable in intervening by cath? Dr. Texter, you mentioned coarc, so I think that's all yours.
Sure, no, that's a great question. So I guess it depends kind of on, what type of, residual arch obstruction. looking at our hybrids, residual coarctation is most commonly coming from some ductal tissue that we just didn't cover. And so our team, if we find a significant residual gradient more than, again, 10 or 12, then we'll usually go ahead and treat that regardless of, since we don't have an arch surgery, that we're worried about. For our COMP2 patients, though, yes, our surgeons like us, unless we're struggling from a clinical standpoint, right ventricular function. If the baby's struggling, then we have to intervene a little bit earlier. But if it's just an echo finding, they like us to wait about 4 to 6 weeks at least.
I think that from the point of view of post-Norwood recoarctation, it's sort of similar in the sense that I think that there are no absolute numbers here. I don't think our surgeons would say, well, I won't touch it for the first 2 weeks. I think that it depends, or that catch wouldn't either. I think it just depends completely on what else is going on with the patient. So a patient who has ventricular dysfunction, increasing tricuspid regurgitation, and an arch gradient is just going to be a very different patient compared to somebody with that same type of gradient, but with good function and with no TR, for example.
Well, thank you. I know that we're a little bit over. I do have one question as a sonographer. The dreaded follow-up echo is a lot of the indications we get for an echo, and a lot of myself included, sometimes we ask ourselves, what are we looking for? And the images you provided were great, but what are we looking for really when all we get is a follow-up echo, and that we or a new sonographer won't recognize that it's emergent, other than the increasing stenosis in our interventions?
I guess I'll take a first shot at that. I really like to have open line of communication with the folks ordering these. I think similar to what Karen talked about, we also have a weekly follow-up protocol, sort of thing for the post hybrid, first stage hybrid, with weekly echoes, and in those we look at everything. Similarly, when we're doing a post-Norwood echo, unless there's a specific thing that is told to us, like we just pull this tube and we want to make sure that there's no accumulation of effusion, or we just pull pacing wires and we want to make sure, or something like that. We basically look at, we look at the record, figure out what's going on with the patient, and most of the time we'll do a full echo. Especially if it's been more than a few days since the last one, or if there's been a clinical change in the patient. I think communication between the sonographers, the echocardiographers who are reading the echo, and the clinicians who are asking for it is all important.
Thank you so much.
Yeah.
Do you have something else, Dr. Texter?
I was just going to add that it is so challenging because these babies hopefully are active and crying and trying to help. That's normal. That means they're feeling good enough. But then it makes your job and our jobs very challenging to make sure we've answered the questions clinically. And so we instituted a huddle recently definitely within our ICU and inpatient services with the Echo Lab to try and do the best we can and make sure we're not missing things, because we'd like to try and do a complete study on every patient, but we know that that's not always feasible. Now, we don't have a process like that in the clinic, though, so we still struggle with issues like that in the clinic.
Well, I guess communication is the basis of everything. So I'll hand it over to Jen Kovu, who will close out for the night and give you some more information. Thank you. Thank you so much to our speakers.
Right. Well, thank you so much to our speakers and moderators. This has been an informative speed webinar as usual, and we would like to thank our institutional sponsors, Seattle Children's, Lucille Packard Children's Hospital Stanford, Nemours Children's Health, Cincinnati Children's, Lurie Children's Hospital of Chicago. And if you're interested in institutional sponsorship, please contact admin@sopeonline.org for more information. And we would like to invite you to our next SOPE Speed webinar, which is on stress echo of hypertrophic cardiomyopathy imaging tips on April 2024. Sorry, that's still 2023. And then Again, just to remind you, for those who don't know, there is a new membership promo with discounted price. If you're a new physician member, sonographer member, these are /50% off. Fellow students and international members, just let us know where you're coming from, and there are different tiers of international membership that are available. And lastly, we would like to invite you to the SOPE Social at American Society of Echo Scientific Session. This will be on June 14 from 6 p.m. to 9 p.m. at Easton Broad in Portland, Oregon. And this is the flyer. You can screenshot this if you are interested. And if you're a member, you could register at the within the flyer that we've sent to you. Again, we would like to thank our institutional sponsors, and we'll see you next time on our next speed. Thank you so much.
Take care, everyone.